Now it is live. Please start. Hello.
Hello.
Ma'am, it is live. Ma'am.
Hello. First.
Okay, ma'am. Because it is live. Good morning, sir. Ma'am, your sir, your voice is
Good morning, sir.
Hello.
yes, sir. Now it is clear, sir. Now it is clear.
Okay, fine.
Okay. Sir, can we start that judging, sir? Sir, can we start, sir?
Yeah, yes, you can start.
Okay. Sir, first one, first presenter it is Nandini.
Okay, fine.
Nandini, please unmute.
Yes, sir.
Hello.
Hello.
Sir, this is poster, sir. Please start, Nandini.
Yes, sir. So, good morning, sir. I'm
Good
Dr.
morning.
I'm Dr. Nandini from Kilpak Medical College, postgraduate final year. My e-poster title is Havel syndrome. Havel syndrome.
The technical team is listening. I'm why our poster is not our poster is not being displayed. It's not on my screen.
Sir, it is displayed, sir.
No, I am getting join the a new window has opened.
Now it is.
Yeah, I am getting some advertisements type of thing on this now.
So once you check that in that Zoom, sir.
No,
In the Zoom only, we will share that.
Zoom, they have suddenly popped up and joined the conversation and all these things.
No, in that Zoom, they just you open your Zoom, sir.
Yeah, I am in the Zoom only. It is opening some.
So you are seeing that all the presenters, sir.
Yeah, I am seeing now all the presenter. In the middle, I am seeing IT support.
Okay, sir.
No?
Once, can you see one now, sir?
Yes. Fine. Now I am able to see.
Please start, Nandini.
Yeah.
Yes, sir. So my e-poster title is Havel syndrome, sir. Havel syndrome, also known as ankyloblepharon ectodermal defects cleft lip cleft palate syndrome. It is a rare autosomal dominant genetic disease with the main features of ankyloblepharon filiform adnatum, ectodermal defects, and cleft lip palate. So we had a term girl baby whose second born of non-consanguineous marriage, delivered through normal vaginal delivery, was admitted in neonatal ICU to evaluate for congenital anomalies. Baby had bilateral ankyloblepharon, left unilateral cleft lip with cleft palate as shown in figure 1. So we suspected ankyloblepharon ectodermal defects cleft lip cleft palate AEC syndrome and evaluated. So the skin, hairs, nails and digits were normal shown in figure 2. On probing, the family history was not significant. The child vitals were stable. Systemic examination was normal. Ankyloblepharon correction was planned and we further planned for cleft lip and cleft palate correction. So genetic testing for this syndrome could not be done due to financial constraints, but baby is on regular follow-up till now. So AEC syndrome, it is a rare autosomal dominant disease caused by heterozygous missense mutation in P63 gene. There are many syndromes which have similar features caused by mutations in P63 gene, such as EEC syndrome, which is ectrodactyly ectodermal dysplasia clefting syndrome, Rapp-Hodgkin syndrome, limb mammary syndrome, acrodermato angual lacrimal limb syndrome, split hand malformation syndrome. So, some clinical features of these syndromes are sharing the features like AEC syndrome, but they all have their own characteristics. For example, EEC syndrome has ectrodactyly, which is not present here, and the ectodermal dysplasia will be less severe in EEC syndrome. In Rapp-Hodgkin syndrome, there will be no ankyloblepharon, and adult syndrome and split hand or foot malformation syndromes will not have any craniofacial cleft. So I want to conclude like there is an importance in the early diagnosis of the syndrome since it is autosomal dominant and should be emphasized to implement appropriate genetic counseling for parents as well as treatment of the complications.
Nandini,
Hello, sir.
no. How many cases have been reported?
Sir, around 10 to 14 cases have been reported so far, sir.
Reported in literature, huh?
Yes, sir.
Yeah, which if you can tell us which of the institutes, if you remember.
So can we go next? Hello. So can we go next? Hello.
Hello, sir.
Yeah, you can go to the next.
Okay, the next Jitendra Singh.
Yeah.
Please unmute Jitendra. Jitendra, please unmute. Jitendra, please unmute.
Hello.
Yes, yes.
Sir, good morning, sir. Good morning, everyone.
Yes, proceed.
I'm going to present a
Yeah.
unusual presentation of type 1 leukocyte adhesion deficiency. Uh, First of all, I would like to introduce what is LED. It's a delayed separation of umbilical cord with persistent leukocytosis and recurrent bacterial and fungal infection involving skin and mucosa and poor wound healing.
Okay.
We present a case of unusual LED in neonates with normal separation of umbilical cord and absence of omphalitis. This baby was 18 days old term female infant, first baby of third degree consanguineous marriage. He came with the presentation of perioral blackish discoloration of skin on day 18 of life. History given by mother suggests that it was started as a bullous lesion 2 days back and it was ruptured spontaneously. They shown to some local practitioner but did not respond to the treatment given by the practitioner. We got a history of cord separation at day 7 of life. The baby was, since day 1, he was on exclusively breastfeed and the baby was gaining weight adequately. In spite of so much severe lesion, the baby was gaining weight adequately. There was no history of fever or decreased feeding at any point of time. Actually, similar one more lesion of erythema and crusting and exfoliation skin was present near the umbilicus and periumbilical region. With same discoloration is onset with the spontaneously with same lesion as perioral lesion. On examination, there was significant abdominal distension was there and significant hepatosplenomegaly was observed. Spleen was 5 centimeter below the left costal margin, soft to firm in consistency. Liver was 4 to 5 centimeter below right costal margin, soft to firm in consistency. And more striking was that there was no pus discharge from any of the skin lesion.
Okay, no problem.
Neither from the perioral lesion nor from the periumbilical lesion. So first we kept the provisional diagnosis of late onset sepsis with bullous simpatico. And the baby was started on antibiotics cloxacillin and amikacin. We got opinion from skin department. They also advised with the bullous simpatico and continuation of IV antibiotics and 2% mupirocin ointment for skin application. Initial laboratory investigation shown hemoglobin 12.7. Actually, leukocytosis were very marked. 85,800 total leukocyte counts. And platelet were 1.8 lakhs. Peripheral smear shown neutrophilic leukocytosis with shift to the left with toxic granules and 10% band forms. So we treated as continuously treated as late onset sepsis. CRP was negative and first blood culture shown no growth. We have continued the antibiotic cloxamica and the lesion shown the signs of healing also. Baby was hemodynamically stable. After that, no further skin lesion appeared during the hospital stay. But what happened on day 7 of hospital admission? Baby had high grade of fever. Previously, the excess there were no history of fever, but after admission in the hospital at day 7 of life, he had fever. So we repeated the counts again. That repeat count also suggests TLC of about 1 lakh, more than 1 lakh. Platelet count shown around 80,000, thrombocytopenia. Then we suspect the leukocyte adhesion defect deficiency and neonatal leukemia. Two possibility we kept. But for neonatal leukemia, we rule out because there is no atypical cells on the peripheral smear as such. No blast cells were seen, no atypical cells seen on perical smear. So diagnosis of LAD was only left with provisional diagnosis, and we did CD11 and CD18 profiles on neutrophils on flow cytometry that found that there is absence of CD11 and CD18 on neutrophils on flow cytometry. So that's how we confirm the diagnosis of LAD type 1 in this baby. And mother and parents was advised for bone marrow transplantation actually. They were ready to get involved in the bone marrow transplantation procedure. And the blood sample of mother and infant we have sent for HLA typing. Reports still awaited actually. Baby discharge after the 14 days of antibiotics. That time we upgraded antibiotics when the baby had fever at day 7 of admission. We upgraded the antibiotics to Mirovenco. We completed the Mirovenco for 2 weeks. Baby had no further sign of any clinical deterioration. Baby was hemodynamically stable, gaining weight. On discharge, we put the baby on quatrimoxazole long-term prophylaxis, vitamin D and supplements given, advised breastfeeding, exclusive breastfeeding. And we asked it to follow up once the HLA reports are available. And parents also advised to avoid all live vaccines like BCG and typhoid alike. And we are awaiting actually the HLA report. Then we will proceed for bone marrow transplantation procedure. Thank you.
Sir, any questions?
Is the child continuing to survive? Is the child still on follow-up?
Yes, sir. Child is still on follow. We are in contact. Baby is on exclusive breastfeed with supplements and syrup cotrimoxazole. Baby is gaining weight. No further lesions, no further clinical deterioration observed, sir.
Oh. Why did you not advise live vaccines? What is the contraindication? What are the contraindication for live vaccines here?
Sir, actually,
Any reports are available that live vaccines
yeah, with antibiotics reduction in the serum level of antibiotics low, that mostly like X-linked A gamma globulinemia like that.
Yeah, but we are not testing any children for immunodeficiency for vaccination, and this is so far not been listed there also. Anyway, the child is exposed to daily infections from environment. Okay, fine. You have done a good work. Okay.
Thank you, sir. Thank you, sir.
Next, Guru Lakshmi.
Hello, good morning, sir.
Good morning.
I'm Dr. Gurulakshmi, postgraduate second year, Cleveland Medical College. My poster presentation is on effects of antenatal breastfeeding counseling on early initiation of the breastfeeding, which was done in our Department of Obstetrics in Government Cleveland Medical College, which was an interventional study. My guide was Devi Meenakshi and Sri Devi A. Narayanan, the professor and associate professor of Department of Pediatrics, Government Kilpak Medical College and Hospital. Background of my study was early initiation of the breastfeeding within an hour plays a vital role in a neonatal care. Even with adequate antenatal care, the rates of early initiations are not adequate in our country. There is a need for effective prenatal counseling to improve the early breastfeeding rates. My objective was to evaluate the effect of immediate antenatal counseling prior to the onset of labor on breastfeeding outcomes in terms of early initiation. The study was done as a non-randomized interventional study in a department of obstetrics, Government Kilpak Medical College and Hospital. Here the data was collected from the two groups. One is an intervention and another is a control group. In the intervention group, we taken as the mother admitted for safe confinement prior to the onset of the labor, where the intervention was given about the counseling was given about the benefits of early initiation of the breastfeeding. Another 110 mothers in a control group where the mother admitted with the labor pain for safe confinement. There we won't give any counseling about the early initiation of breastfeeding. And after delivery, both the groups are followed up, and the rates of early initiation was taken with a pre-tested questionnaire. The intervention group, in both the groups, we collected the information about a maternal age, education, morbidity, and normal number of antenatal visits, mode of delivery, timing of initiation of the breastfeeding, knowledge about early initiation of breastfeeding. The frequency percentage calculated and independent t-test was used to compare the means in between these two groups. Out of this, the results are in intervention group, the knowledge about the breastfeeding and initiation of the breastfeeding was better when compared to the control group. In 110 mothers in the intervention group, the 72.7% mothers, like 80 mothers, breastfed within an hour. About 105, that is 95.5%, acquired a knowledge about early initiation of the breastfeeding in intervention group. In control group, only 56 mothers, that is 50.9% of the mothers breastfed within an hour. The knowledge also significantly low in the control group, which is 46.3%. The results, the reason for the mainly delay in the early initiation of the breastfeeding is not aware of about early initiation of breastfeeding, and inadequate secretion of the breast milk was given by the as a reason for the from the mother's side, and some of the mothers given a pre-lactal feeds also. So in our study, the conclusion was the counseling has resulted in improved rates of early breastfeeding. And due to the immediate counseling prior to the delivery, we found a marked increase in the knowledge about the early initiation of breastfeeding in the intervention group. Thus, our study emphasizes the importance of increasing awareness about the early initiation of breastfeeding during the antenatal visit, and also reinforcement prior to the delivery about that. Thank you, sir.
So any questions?
No question. This is done in a very small group.
Yes.
No?
Yes,
And
sir.
there are a lot of other things that go on to initiate, because it's not the doctor alone who counsels, it is also anyone who are the caretakers around the mother would continue
Yes.
to counsel, no? So
Yes.
this can't be an absolute thing as counseled and not counseled. It's very difficult there, because every day they have been counseled, they are watching the other people also in the wards. You have not kept them separate. They are from the general antenatal wards, no?
Yes, sir.
So when counseled, the others are also watching. So, so people pick up clues, and also they will be counseled by the relatives, all of them simultaneously. But anyway, the counseling definitely, you have shown that it definitely reinforces or the breastfeeding rate, initiation rates. Okay, did they receive any help in the postnatal in the labor room for initiating? How was
Yes, sir.
the initiation of breastfeeding verified? Whether it was done in the half an hour? Who had observed this? Is it by a questionnaire that you have asked
Yes,
after that,
sir.
or this? Huh?
It's only by questionnaire, sir. By questionnaire.
Only by questionnaire. Yeah,
Yes, sir.
okay. They are likely to be biased in questioning because you know the groups, no?
Yes, sir. I know.
Yeah, so there could be bias. Okay, fine, thank you.
Thank you, sir.
Next, Rajashri.
Good morning, sir.
Good morning.
I am Dr. Rajshri, pediatric postgraduate from PSG Institute of Medical Science and Research, Coimbatore. The title of my study is Clinical Profile and Outcome of the Neonates Born to SARS-CoV-2 Infected Mother. It's a cross-sectional study conducted from March 2019 to February 2020, that is during the peak of COVID pandemic. I conducted the study with the help of our guide, Dr. Rajesh. As we all know, SARS-CoV is a respiratory virus with increased morbidity and mortality among adults. Though the vertical and perinatal transmission of SARS-CoV-2 infection to the babies is documented, their clinical presentation and outcome are less described, especially in our Indian context. So our aim is to study the clinical profile and outcome of the neonates born to SARS-CoV infected mothers. The objective of the study is to identify the incidence of early neonatal comorbidities in the study population. So in our study, total 98 neonates were born to the SARS-CoV-2 positive mother, of whom 50% of the babies were female, and their mean birth weight was 2,942 grams. Among 98 neonates, 2 neonates were lost to follow, and 96 babies were followed till discharge. Of them, 79.6% were term babies, and 20.4% were preterm babies, with a mean gestation age of 34.95 weeks. Of all 96 babies, 7 required respiratory support. Of them, 2 were term and 5 were preterm babies. The neonatal comorbidities that are documented from our study are respiratory distress syndrome, which is seen in 15%, hypoglycemia seen in 15%, probable sepsis noted in 10%, and neonatal jaundice was noted in 20% of the preterm babies. And there was no mortality due to COVID pneumonia or COVID-related complications in the babies born to SARS-CoV infected mother. So to conclude, the neonates born preterm to the SARS-CoV infected mother had increased morbidities compared to the term neonates. However, these morbidities are similar to those seen in preterm born to non-COVID infected mothers. Thank you.
Okay. So COVID make no difference in the morbidity pattern. Huh?
Preterm, these are all the common complications seen in normal non-COVID mother preterm babies.
Okay, so there is no difference.
No,
COVID
sir.
is not causing any harm. That's your conclusion. Is it active COVID during labor or during this period, or it was a history of past COVID infections in these mothers?
No, sir. Active COVID during the period, sir.
So they were all actively COVID. Huh?
COVID positive within 7 days before labors.
Okay, so you have not seen any difference in the profile, clinical profile, when compared to your other non-COVID mothers in your hospital?
Yes, sir. There is RDS hypoglycemia and are all similar to those in to the non-COVID infected mothers.
COVID is not causing any harm to babies.
From this study,
okay, was babies also tested for COVID?
Yes, sir. 86% of the babies were tested COVID within 48 hours after delivery, and none were found to be positive. We did RT-PCR for the testing babies.
Okay, so that would only find out the vertical transmission, no? Within 48 hours?
Yes, sir.
You have not done one extended thing because they are being handled by the mothers. Are they handled by the mothers or by the unit? Yes,
sir, by the mothers only, sir.
Mothers only.
With
so
the help of the
weeks of exposure like that.
So we advised early discharge and early follow-up within 7 to 14 days after discharge, sir. But 60% of the came for follow-up, and only 20% did repeats RT-PCR. Of them were also found to be negative.
Fine, thank you.
Thank you, sir.
Next is Siddharth. 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 So can we go next, sir?
Yes, sir. If someone is not joining, go to the next. We'll come back up.
Maria
Probably
Joseph.
have it.
Maria Joseph. Maria Joseph. Next, Kishore.
Good morning, sir.
Good morning.
I will share my screen.
Yes, please.
Is it visible, sir?
Yes. You
Good
can
morning.
proceed.
Yes.
Good morning.
Sir. As we know, the prematurity is the most common cause of neonatal mortality rate. And despite robust evidence, the coverage of antenatal steroid in low to middle income countries are still low compared with high income countries. So my topic of my study was knowledge, attitude and practice among the obstetrician of Tamil Nadu towards the use of antenatal corticosteroids. It was a multi-centered descriptive study done in various hospitals in Tamil Nadu, conducted between March 2021 to June 2021, where our obstetrician filed a predetermined questionnaire responses. The questions has been derived from the ACOG guideline and reviewed by the expert committee of the Mehta Hospital. We got total 217 responses. Out of that, 97% physicians are using antenatal steroid routinely for the preterm birth. 43% are using for the delivery less than 34 weeks, while the 24% are used till 39 weeks. 69% are using the betamethasone, while the 31% are using the dexamethasone, which was recommended by the government of India. Surprisingly, only the 9% knows the exact composition of betamethasone molecule that need to be used. 65% are using in the multiple pregnancy without any risk factor for the preterm birth. 47% believe that there should be at least 24 hours difference gap between the last dose of steroid and the delivery, while the 35% believes there should be 48 hours minimal gap. 54% don't use it in the routinely for the elective LSS at the time, which is recommended by the government of India. 86% are using in the case of mother having gestational diabetes mellitus. 70% believes there is a good neurological outcome to the baby after giving antenatal corticosteroids. 84% are fear to use during the maternal systemic infection, while the 43% are not using routinely in IVF pregnancies, 57, which is the recommendation, while the 57% are used routinely. 89% are using in case of premature preterm rupture of membrane, especially ELBW cases. And the repeat course of steroid, 57% are repeating it, but as of now, government of India doesn't recommend it, and 43% is not using it. So to conclude, my study highlights that there is a knowledge and practice gap, and there are areas of improvement in antenatal steroid coverage among the healthcare worker. Thank you.
How was the study done?
Sir, we designed a pre-questionnaires and we have sent it to mail or through offline mode to the various hospitals in the Tamil Nadu and got their responses.
Okay, you have sent the mail to the obstetrician.
Yes, sir.
And what they do is, because you are not in person to verify whether they are answering offhand or they are referring to someone and then answering, no?
Yes, sir.
Yeah, so this is not a real test, because most of them, when it comes to given a questionnaire, they tend to consult and counsel with others and before answering, because no one wants to exhibit their lack of knowledge.
Sir, we didn't kept the option of disclosing their name. We just given the numbers to the form.
Even if you are not disclosing, no one wants to do. So the actual facts that they have been given may not be the one that probably they are practicing or knowing. Unless you have done it, catch them offhand and then give a questionnaire in person and then collect it. So this you have sent by mail, and you have given them time to refer and all these things. And they will want to, it is the usual intention of everyone that they want to do well on those questionnaires. Okay, anyway, you have tried one, but I think the facts may not be the actual one that is prevalent in the practice.
Yeah, despite of this, sir, still the coverage is quite low. Despite, and the knowledge is still there is a gap between that.
Yeah. We have to give a correction for that thing.
This will
And then
can form a
probably-
platform us to do the quality improvement study and taking routine workshop following them to increase the antenatal coverage.
Okay. Okay.
Thank you, sir.
Thank you.
Next, Maria Joseph.
Hello.
Yeah, yes. So good morning. Let's start.
Hello, good morning.
Yeah, good morning.
The topic of my poster is fighting the mighty, that is the meningitis by multi-drug resistant Elizabethia kingia meningosepticum, a single extramural study experience from our center. So basically this Elizabethia kingia meningosepticum is a non-fermentative gram-negative bacillus which causes neonatal meningitis with very severe post-infectious sequelae. The infections are very difficult to treat because of its inherent resistance to extended spectrum beta-lactams. So the aims and objectives were to study the clinical profile, antibiotic sensitivity, complications and outcome of the organism-related meningitis in the newborn. The materials and methods, we had 10 neonates with Elizabethia meningosepticum meningitis who were admitted in NICU, and they were studied for a period of 2 years. I'm sorry, like I'm not able to see the screen fully.
Your screen is visible, huh? Yeah.
No, now it's okay. Yes. So the 10 neonates were admitted in NICU KKCTH from January 2018 to August 2021 were retrospectively studied. And all the relevant data pertaining to demographics, clinical profile, antibiotic susceptibility, and treatment outcome were analyzed in our institute. And we found that 10 of them had the infection, out of which 7, that is 70% were term, and 60% were males. The median range at presentation was 10, and the days of shunt placement was around 15 days. And they required around 18 days for the clearance of infection. And we also noted that there was no associated bloodstream infection or seedling of microabscess observed elsewhere. And all these babies, all the 100% of the babies required reservoir placement prior to shunt placement. So these are the clinical features that we have noted. That is all babies, the 10 babies had hydrocephalus. And 8 of them had seizures requiring more than 2 anti-epileptic drugs. And fever was present in 7, that is 70%, irritability in 5, and poor feeding noted in 4 of them. So these are the clinical features that we observed in this meningitis. And among the lab investigations, we found that CRP was positive. They're highly positive in more than 10 in 3, that is 30%. Borderline positive, that is between 6 to 10 in 3, that is another 30%. And CRP was actually negative in 40% of the babies. And the CSF culture was positive in 9 out of 10. And the one, the left had a genomic PCR positivity for the same. Eubacterial genome picked up the meningitis. Thrombocytosis and leukocytosis was present in 50%, that is 5 out of the 10. And regarding an antibiotic sensitivity, we found that 70%, that is 7 out of the 10, was sensitive to levoflox, and 4 out of the 10 sensitive to vancomycin, and 1 was sensitive to minocycline. So we administered a combination therapy of levofloxacin and vancomycin to 8, that is 80%, levoflox with cotrimoxazole in 1, because one of them was sensitive to cotrimoxazole, and levoflox with minocycline in 1. So most of our babies, that is 80% of them, received a combination therapy of levoflox and vancomycin. And we had quite a good outcome. That is, out of 10 babies, in spite of the complicated meningitis with ventriculitis and hydrocephalus, 9 of them survived. Only 1 expired. And all required shunt placement. At the time of discharge, they were seizure-free and with the normal tone at discharge. We are still following up the babies in our OPDs, and so far, all of them have good neurodevelopmental follow-up also. So conclusion, Elizabethia kingia meningosepticum infection presents mostly with complicated meningitis, ventriculitis, and hydrocephalus. Early and timely combination therapy with Vancomycin and levofloxacin for 6 to 8 weeks reduces mortality and morbidity. Thank you.
Good. This is a common organism that is causing meningitis?
This is not a very common organism, sir, but the case reports have
other
been.
Reports from other tests?
We have quite a few literature where neonatal meningitis have been reported by the same organism. Though rare, it's a very notorious organism known to cause meningitis, very complicated meningitis.
When KKCTH, it seems to be very common, 10 within 3 years, no? 2018 to 21.
Yeah. Yes, sir. In last 2 years, 2.5 years.
Other centers have not reported this as commonly as you've been reporting.
Yes, sir. That's why we wanted to do this.
Okay. Is it because they are not able to identify, or probably you have used any particular culture medium suspecting this?
Sir, it could be because we were able to identify this organism because we have had a few experiences in we have in the last 2.5 years. So these clinical features, we have a very strong suspicion of this complicated meningitis by the same organism because we have had experience in the last 2 years. Okay. So we are easily picking it up, and we had to do even eubacterial genome analysis to pick up in one of the babies, even when the culture was sterile.
Literature from your institute prior to 2018, were there any case?
Actually, we have cases, but very few, sir. We have 2 or 3 cases.
There is suddenly an increase of these organisms now causing the septicemia and meningitis.
Excuse me, sir. Like I didn't get, sir. Do you mean?
Is there a sudden increase in the incidence of this organism in these 3 years? Past, not many have reported. Not many centers.
In the hospital literature, definitely compared to prior to 3 years, there is an increase, sir. But we are outborn, sir. So we have babies from different parts of South India. So it's not a clustering. From different parts we have.
Okay. Okay. Thank you.
Okay. Thank you, sir.
Next is Siddharth. Hello, Siddharth.
Can you hear me, sir?
Yeah, yes, Pa.
Yes.
You're audible.
Sorry, I had a small technical issue. I apologize. I was not able to come here earlier. Good morning, everyone. The poster I'm presenting today is our experience in managing airway in neonatal Pierre-Robin sequence. So Pierre-Robin's sequence, as we know, is historically is a craniofacial disorder which is usually associated with the triad of micrograthia, glossoptosis, and cleft palate. And it typically the management would of course not just be limited to the neonatal period, but it extends into pediatric age group where there is a significant follow-up that is required, but only for a small number of individuals. In majority of the cases, traditionally what has happened is especially if they're non-syndromic, a conservative approach is usually sufficient. So we wanted to look at in the methodology, we just looked at our cases in the last 5 years and see whether there was a change in how we had managed these cases. So in the last 5 years, we identified 27 patients. In these 27 patients, only 16, that is about 60% were managed conservatively. In 41% of the time, they required some form of respiratory support. So this respiratory support was either in the form of high flow nasal cannula, CPAP, either nasopharyngeal or CPAP, or invasive ventilation. In this 11 that required some form of respiratory support, 6, we went ahead and performed an airway endoscopy. Transnasal flexible nasal endoscopy was performed. And out of the 6, almost a significant number had other airway issues that required surgery in the form of supraglotoplasty. So if you look at some of the pre-op photos, the main thing that we wanted to highlight is that usually it has been the case that if there's a significant airway issue, we limit ourselves to either managing conservatively, either in prone position or airway oxygen, or a simple tongue lip adhesion procedure is performed. But what we identified is that in a significant number of patients who require some form of airway assistance, there are other very easily correctable anomalies that are identified. So if you look at some of these photos, the first pre-op flexible endoscopy, we find that there are many cases where there is laryngomalacia, the posterior falling of epiglottis, and some of these can easily be managed with an epiglottopex or a supraglottoplasty. And post-operative, in almost 4 of these babies, we were able to significantly cut down. So if you look at the table, I had highlighted
Things are worried, you can always call. Okay.
a significant who required a significant length of hospital stay. So we had 4 of these babies who required a hospital stay of more than 1 month. And post a simple procedure of managing the epiglottis, either in the form of an epiglottopexy or a supraglottoplasty, we found that within a period of almost 7 to 10 days, we were able to wean the baby from invasive ventilation to non-invasive. And subsequently, we are, over the course of time, either with nasopharyngeal CPAP, as I've pictured here, or in some cases where subsequently in the pediatric age, we were able to perform a mandibular distraction and thereby ensure that their airway is good. Because it's very essential to take care of these airway issues, because it causes issues not just with breathing, but also affects nutrition and weight gain. So overall, I just wanted to conclude that in our experience, we find that there are other anomalies which are there, with such as an isolated laryngomalacia that may be present apart from the conventional triad, and performing in certain cases, depending on the airway finding, an epiglottopexy or supraglottoplasty or a combination along with the tongue lip adhesion may actually be beneficial. And my main goal was to tell the community that we have to look beyond conservative and just tongue lip adhesion, and there are other modalities which are there. Even in our own findings, in our own thing, if you look at pre 2015 and post 2015, we find that post 2015 our approach to these babies have changed, and we are actually a little more pro airway endoscopy to identify these small problems. And once these are identified, these babies come out quicker. So that's the message I want to bring across. Thank you, sir.
What was the main difference that you have observed, reason for the difference you have observed before 2015 and after 2015?
So the main things are actually, we went through our archives. A main thing was that pre-2015, the general tendency, at least in our institute, was that the ENT surgeon was not almost always involved. It would be the plastic surgeon where a palatoplasty or an obturator was usually placed. And in majority of cases, there would be a significant loss to follow up, or they would be having poor weight gain when they would come back in the pediatric follow up.
What made the difference?
So I think a general understanding, there has been a I think there is a general improvement in our understanding of the disease, sir. If you look, there is no specific treatment protocol that is there. When unit to unit, country to country, the management changes, and there isn't a specific thing. There aren't any papers that are highlighting that these other anomalies are also identified. I think it is something that over time and experience we have realized that these things can easily be corrected, and there has been a change in our management of this, and I think this is something that everybody needs to do, because if you look in literature, nothing specific about something like this is actually available. So
change in management has come with the change in the persons who available, or
sir. In fact, from 1999, Dr. Thiru, our ENT surgeon, the same surgeon has been there for many years actually. But I think this is something that he observed, and his general, I think overall his observation has suggested that there has to be a certain change in the way we manage these babies. And in our own unit, we are finding it's extremely helpful. So we get referrals from from other places where they've been on invasive NT for more than 2-3 sometimes a month, and then sir comes and we end up doing this. Our post-op management also becomes
So it
quite
is the skill of an
reasonable.
individual person that is making a difference in this.
Pardon me,
approach.
sir.
It is a skill of certain individual person that is making
Not
this
an individual approach. No, sir. It
overall
is
understanding of
the
this.
overall understanding. I think there is a shift in our understanding of this condition.
Okay.
Not just a skill, because supraglotoplasty and apexis are very routine surgeries that are being performed for other babies. But this is something that we should include in this specific group of syndromes. Sir.
Fine. Thank you.
Thank you, sir.
Next. Next, Sankavi.
Good morning, sir. Good morning, sir.
Good morning, Pa.
I am Dr. Sangavi, final year postgraduate from Chengalpet Medical College. My poster is based on an observational study which is done to determine the feasibility and efficacy of skin-to-skin KMC via Kanga sling in reducing the procedural pain in neonates. It was conducted in the Department of Neonatology, Chengalpet Medical College, Chengalpet. Gangrene mother care contribute to reducing pain in neonates by several mechanisms, like by calming the baby, reducing the level of stress, oxytocin release, and causing the blockade of the transmission of nociceptive stimuli by providing the continuous tactile stimulation. And according to the researchers, the basic connections in the pain pathway are well formed before 30 weeks of gestation. The objective of my study was to determine the feasibility and effectiveness of skin-to-skin KMC given via the Kanga sling in reducing procedural pain in neonates as assessed by the premature infant pain profile. Methodology: the study was actually begun as a pilot study to ensure the feasibility of KMC via the sling. It was actually initially difficult to do the heel prick for CBG monitoring while the baby is on the KMC. And this difficulty was overcome by asking the mother to wear a front open dress to enable us to perform the procedure while keeping the baby in KMC. And also, sling KMC requires only some degree of exposure compared to the routine KMC. So it keeps the mother motivated in practicing KMC via sling, proving the feasibility of sling KMC. And a total of 68 babies were taken in the study, and babies of birth weight less than 2.5 kg and gestational age of less than 37 weeks that required venipuncture for blood sampling or CBG monitoring via heel prick method were included in the study after informed parental consent. And asphyxiated neonates, ventilated neonates, or those with congenital malformations were excluded from the study. And PIP score was done 1 minute before the procedure, 1 minute after, and 5 minutes after the procedure. Scores of 0 to 6 indicate that the infant has minimal or no pain, and scores of 7 to 12 indicate slight to moderate pain, while scores of greater than 12 indicate severe pain. The table, I've given the PIP score, the mean PIP score. 1 minute prior to the procedure, the mean PIP score was 5.13 plus or minus 1.884. And 1 minute after the procedure, the mean PIP score was 7.63 plus or minus 2.291. And 5 minutes after the procedure, it was 4.96 plus or minus 1.888. And the mean PIP difference between the baseline and 1 minute after the heel prick was 2.5 plus or minus 0.360. So p-value, I got a p-value of less than 0.001, which shows the p-value is significant. To conclude, the results of the study was mean PIP score using the sling KMC after 1 minute indicate that the neonate experiences slight to moderate pain after a painful procedure. And the mean PIP score of sling KMC after 1 minute was 7.63 plus or minus 2.291, which was very less compared to the previous studies with routine KMC. My previous study reference was from the Indian Journal of Neonatal Medicine and Research, which was published in 2018 January. In that study, it was shown that using a routine KMC, the mean PIP score has come to about 10.8. But for me, using the sling KMC, the mean PIP score was only about 7.63. To conclude, I'm saying that KMC via sling is feasible and effective in reducing the procedural pain in neonates. Thank you, sir.
Thank you. Did you also study the amount of pain and the stress the mother would be undergoing when you're doing a procedure with her by the side?
Yes, sir, but comparatively, the baby has been getting like
One
less pain
aspect
only.
is the pain. One aspect is the pain of
Yes,
the
sir.
baby. Then another aspect, the mother undergoes the pain and stress when you are sampling with the mother by the side. And
So, but
to compare this with the baby's other method of caressing the baby or touching the baby and consoling versus KMC, now we need to choose which is a better method for alleviating pain while sampling. So because here you are having the mother by the side, and the mother
Yes, sir.
might be undergoing through a lot of stress and strain when she is observing her baby being pricked.
Yes.
Yeah.
Sir, but actually, while the baby is on KMC, it actually experiences less pain only, sir. Baby usually doesn't cry while on KMC. So mother is also like little comforted only, sir.
Yeah, see, you are reducing pain on one side for the baby, but increasing the pain and stress on the other side for the mother, I think. Anyway, this good study that you have shown that skin-to-skin contact is definitely helping to relieve pain. Thank you.
Thank you, sir.
Technical team, is there next person? Sangavi is still not signed out?
Sir, good morning, sir. I am Pavitra, sir. I'm continuing my speech with
You're ready to see us. Yeah. You are using Sangavis. Okay.
yeah, sir. Sanghavi, sir.
Yeah. Yes, you can share your screen and start presenting.
Okay, sir.
Share screen and press on the.
Yes, sir. I'm working on it, sir.
Share screen will be on the bottom lines. You first press that, then only your screen will get shared.
Okay, sir.
Yeah.
Sir, is my screen visible, sir?
Yeah, yes, Pa.
Good morning, sir. I am Dr. Pavitra, final year postgraduate from Chengalpattu Medical College, sir. My topic is use of oromotor stimulation for reducing the length of the hospital stay in preterm neonates between 28 to 32 weeks. Sir. The purpose of my study is that preterm neonates less than the 32 weeks have an oral feeding difficulties due to the lack of coordination of the sucking, swallowing, and the breathing, and immaturity of their oral motor structures, and inability to maintain then physiological stability. And they are also exposure to then a lot of negative oral stimuli like mechanical ventilations. These factors lead to then feeding difficulties, and ultimately it lead to the prolonged length of stay of the hospital stay. Objective of my study is that to assess then effect of then additional oromotor stimulation along with our routine non-nutritive sucking and KMC will reduce the length of the hospital stay in preterm neonates.
Neonates included in the study are hemodynamically stable neonates between 28 to 32 weeks and who are off respiratory support and tolerating minimum oral feeds of 30 ml per kg for at least 12 hours. And they are excluded if they have any craniofacial malformation, major congenital anomalies, and birth asphyxia. I have used an oromotor stimulation proposed by the Fusel protocol. I have used this Fusel protocol because it is self-explanatory and it does not need any formal training. In this protocol, they have used a specific oral motor technique for stimulating the cheeks, lips, gums, and the palate for about 15 minutes. Many researchers have found that stroking the cheeks will enhance the sucking rate and supporting the chin and the jaw support will enhance the sucking efficiency of the preterm neonates. The methodology is a randomized control trial by simple randomization method. Study duration is in 4 months. Study population is all hemodynamically stable neonates admitted in the level 3 NICU between 28 to 32 weeks. The sample size is 16 neonates arrived by reducing the baseline transition of 5 days for full oral feeding. Now we have taken the 36 neonates for analysis of the study. The results of the study, both the control and the intervention groups, hospital stay are 19 days. Discussion, the mean gestation age for the control and the intervention group is 31 and 30.6 weeks with no significant change in the baseline characteristics. And also the birth weight of the both groups comes around 1,400 grams. And the infants enrolled into the mean age of 4.9 days in the control groups and 3.8 days in the intervention groups. Infants in the intervention groups attained the full palliative feeds before 1.9 days than the control groups, and the partial breastfeeding 2.6 days than the control groups. But the mean hospital stay between the two groups does not have no significant difference. It have both have 19 days. This is due to the fact that other than the established oral feeding, other confounding factors are also related to the discharge criteria. So the use of the oromotor stimulation is better studied by the transition time from tube feeding to the oral feeding. Our study is continuing the analysis for analyzing the reducing time of transition time from tube feeding to oral feeding. The conclusion of the study, this study does not show a significant decrease in the length of the hospital stay between the intervention and the control groups. Thank you, sir.
Yeah. You are studying that we already know that oromotor stimulation effectively enhances the feeding practices.
Transition time, yes, sir.
Yeah, transition time, that it enhances the maturity of sucking, swallowing, everything. Was it
Yes,
ethical to withhold this already established method for some of the babies in a nursery?
Sir, I can't get it, sir.
No, was it ethical? Now stop this practice of oromotor stimulation in the control group.
Yes, sir. Actually, in our hospital, we have not practiced any oromotor stimulations, started any oromotor stimulation. This is the first study we are going to conduct. So we started as a randomized control.
Entire practice of oromotor stimulation is already an established practice.
Yes,
it's not
sir.
something new.
Yes, sir.
So you have withhold this established practice for some of the babies.
Yes, sir. Actually, we are practicing the routine care, that is non-urinary sucking, and then KMC for the babies, sir. So other babies does not get
something newly introduced in your nursery.
Yes, sir. Yes, sir.
Okay, fine. Okay, thank you.
Okay, sir. Thanks.
Can we go next?
Yeah, yes, sir. You can go.
Pavitra.
Pavitra is the one who finished now.
Okay, the next it is Suchitra.
Good morning, sir. Am I audible?
Yes, yes.
Yeah.
Good morning, everyone. Today I'll be presenting the poster on our study, The Changing Trends in Microbiological and Antibiotic Profile of Bloodstream Infection in Neonates. The introduction is the changing microbial pattern and their sensitivity threatens the emergence of multi-drug resistant strains. And the aim of our study was to identify the microbial profile, their antibiotic sensitivity, and their trend during the study period. It was done as a retrospective cross-sectional study from Jan 2013 to June 2020. And all the units with blood culture positive sepsis were with isolation of a single organism were identified. Coming to the results, among the 21,749 live births, 228 neonates had 258 positive blood cultures during the study period. And the most common organism isolated was Klebsiella pneumoniae, followed by coagulase negative Staphylococcus and Acinetobacter. Though there was difference between the microbial profile among the early onset and late onset sepsis groups, the difference was not statistically significant. However, if you look at the trend of the gram-negative organisms across time, we can see that there is an initial period of the study, the microbial pattern was dominated by Klebsiella, whereas during the middle part, it was dominated by Acinetobacter, and later again it changed to Klebsiella with variation in other organisms as well. In the gram-positive organisms, it was initially dominated by coagulase negative Staphylococcus, whereas in the later part of the study, it was dominated by Enterococcus. So the trend shows variations across the time period. Moving on to the overall antibiotic sensitivity, among the gram-negative organisms, it was presented for the commonly used antibiotics in our unit. Ciprofloxacin only had a sensitivity of 50%, overall sensitivity of 50%, whereas amikacin and meropenem showed a moderate sensitivity of 75%, and the third-line antibiotic colistin had a sensitivity of close to 95%. Among the gram-positive organism, fortunately, vancomycin and linezolid showed a sensitivity of 100%, whereas the commonly used clindamycin and cloxacillin showed a sensitivity pattern of 58% and 36% respectively. If we look at the trend over time, colistin had least fluctuations, whereas the ciprofloxacin had varying fluctuations across the time period, with the lowest close to 20% sensitivity in 2014. In gram-positive organisms, as already mentioned, vancomycin and linezolid had 100% sensitivity throughout the study period, whereas the clindamycin and cloxacillin had varying fluctuations with close to sensitivity close to 0 and to 20% during the study period. And multi-drug resistant organisms were also identified. The multi-drug organisms were defined as resistant to more than or equal to 3 classes of drug. Gram-negatives had 48% multi-drug resistance strains, of which Enterobacter had the highest multi-drug resistance of 68%, and gram-positives had a 39% multi-drug resistance. To conclude, the microbial pattern and the sensitivity pattern has temporal changes, that is, along with time there are many changes, and a continuous scrutinization is required to identify the microbial profile and thus to prevent the emergence of multi-drug resistant organisms. Thank you.
Your data seems to show that on time to time, some outbreaks have been modifying your graph, Klebsiella dominating throughout the decade.
Yes, sir.
Did you compare the Klebsiella's sensitivity pattern with from 2013? What was the pattern, and in 2020, what is the pattern?
It is
for a single organism? Is it showing a difference?
It's not.
You have taken both all the gram-negative together for comparison and all the gram-positive together.
Yes, sir.
Could you individually analyze what was the Klebsiella's sensitivity pattern in 2013 versus what it is now in 2020?
So it's again showing statistically significant. It's not statistically significant, but it has a waxing and waning courses. Sometimes meropenem, if we see it initially had some, in some places it shows 90% sensitivity, whereas it sometimes whenever there are carbapenem producing organisms, the meropenem sensitivity comes down to as low as 50%. And the next year, with the different profile of organisms, it changes.
So the sensitivity pattern for the same drug keeps changing, huh?
Yes, sir. So which is why we need to monitor continuously, like look at the R unit's microbial profile, and then choose the antibiotic, change the antibiotic policy of the unit based on the antibiotic profile, maybe at least every year.
Okay. Thank you.
Thank you, sir.
Ajit, are there anyone else left?
Yes, sir. Yes, sir.
Good morning, sir. My name was Nick, sir, in the list.
Fine. Introduce yourself and then start presenting.
Okay, sir. I am Dr. Meghna, sir. I'll share my screen, sir.
Yeah. We are ready to see your screen.
Is it visible, sir?
Yes, Pa. There you are.
I'm Dr. Meghna. Today I'm presenting my study, a study done titled Clinical Profile, Immediate Outcome and Perinatal Consequences of Neonates Born to COVID-19 Positive Mothers. COVID-19 has a diverse clinical spectrum and literature is constantly evolving with more data and evidence-based studies. We aim to analyze the clinical lab profile and outcomes of neonates born to COVID-19 positive mothers. We also aim to compare the various parameters between the two waves. Ours was a prospective study started in March 2020, and we took it up to July 21. And by the end of the study, we compared retrospectively the data between the two waves. Maternal data included the age, antenatal risk factors, comorbidities, symptoms of COVID-19, the lab data, and time from COVID RT-PCR positivity to delivery. The delivery and resuscitation details were documented. Natal data included gestational age, the birth weight, clinical and biochemical details, treatment profile, and outcome. Since there are multiple parameters here, I'm highlighting only the significant ones. Regarding the maternal comorbidities, there was a significant increase in mothers presenting with GDM nearly 5 times. The spectrum of symptomatology also was increased and diverse, though the percentage was similar between the first and the second wave. The severity of symptoms were, however, higher from 1.6% in the first wave to 17% in the second wave. And time from positivity delivery, we included the mothers who turned positive 7 days prior to the date of delivery. And it was 1.6 days in the first wave, and in the second wave, it was 2.1 days. We also had a statistically significant finding of oligohydramnios in nearly 40% of the mothers in the second wave. Also, the biochemical parameters relieved an elevated CRP of 60%, ferritin of 33%, and interleukin-6 of 43%, and all of them had positive correlation with oligohydramnios with a p-value less than 0.05. Regarding the gestational age, 17% were born preterm in the first wave, whereas 30% were born preterm in the second wave. Also, among the 17% in the first wave, majority of them, that is 13% of them, were late preterm. We also found out that there was a twice higher need of resuscitation in the second wave. Regarding rooming in or isolation at NICU, the parents were counseled and 100% of them opted for isolation at NICU in the first wave, whereas 3.5% opted for rooming in the second wave. And all the babies in both the waves were given express breast milk. Throat swab evaluation was done to the babies at 48 hours of life and subsequently on 7, 14 or 28 days based on the clinical symptomatology of the child. Regarding symptomatology, we found that respiratory system was involved 98% of the babies in 9.8% of the babies, whereas 16.9% of the babies had a respiratory involvement, and need for mechanical ventilation was also higher in the second wave. Regarding cardiovascular system, there was nearly 5 times higher babies presenting with need for intensive management. Neurological system also was involved nearly 2.5 times higher than that of the first wave. Regarding the management, 5.5% alone required intensive management in the first wave, whereas 13.5% needed medications like IVIG, remdesivir, and higher antibiotics during the second wave because of presence of sepsis. Although the lab parameters in the mothers were higher with in an increased inflammatory milieu there, in neonate it was only in 8.4% of the babies. We had 100% survival in the first wave, whereas we lost 3.3% of the babies in the second wave. On comparison, this is what we would like to highlight, that we had mothers presenting with higher risk factors, with greater severity and a bad inflammatory milieu, and increased in oligohydramnios. There was increase in prematurity, twice in higher need for resuscitation, higher symptomatology, but still we had lower COVID positivity, and the lab parameters did not reflect as in the mother's milieu. I would like to conclude saying that majority of neonates born to COVID-19 positive mothers were negative to RT-PCR. Express breast milk and rooming appeared to be safe. Second wave saw higher morbidity despite lower COVID positivity among this population. The strengths of our study was it included data from both the first and second wave, and we have compared both the maternal and neonatal data. We did have a limitation in the form of we did not evaluate for COVID-19 in the gastric aspirate or the urine of the neonate because there was insufficient evidence for the same. Thank you.
Yeah, thank you. What are the CVS problem increase you have seen?
Sorry, sir?
CVS, there is a 10%.
Yes, sir. We had children presenting with higher number of shocks. So like we had 1.9% of the babies and 10% in this one. And in the persistent ductus arteriosus also was higher. Regarding VST and the need for inotropic support also was higher. The mean duration in the first wave was around 24 hours, sir, but it was 56 hours in the second wave. So they needed inotropic support for a longer duration. And
no, you thinking in terms of a teratogenic nature of this COVID virus because your serious anomalies are on the rise?
Yes, sir.
Shock means it could be related things, but was the structural anomalies on the, did it show increase?
Yes, sir. Structural anomalies did show an increase, sir, but it was not statistically significant, sir. So I have put it up in percentages.
Okay. Where was this study done?
It was done at Dr. Mehta's hospital at Chennai, sir. It is a single center study.
All the 110 of them were attended there, huh?
Sir, out of 110, around 20 of them were extramural, sir. We received the babies immediately post delivery. We went, attended the delivery, and received the babies, sir.
Okay, fine. Thank you.
Thank you, sir.
Next, Spruti Chaudhary.
Good morning, sir.
Good morning.
I'll be sharing my screen.
Yeah.
Sir, is my screen visible?
Yeah, yes, Pa.
Good morning. I'm Dr. Spruti Chaudhary, pediatric postgraduate from Chettinad Hospital and Research Institute. So my poster today is about a study conducted under the guidance of Dr. Giridhar and Dr. Usha. The title of my study is Predicting Significant Hyperbilirubinemia in ABO Incompatibility. Is cord blood direct antibody test useful? So blood group incompatibilities is the most common hemolytic cause of neonatal hyperbilirubinemia. Even though RH incompatibility is more severe, ABO incompatibility is more common. So commonly used screening test for blood group incompatibility is direct antibody test or DAT, also known as direct Coombs test or DCT. As per AAP guidelines, routine cord blood DAT or DCT is being performed in RH incompatible births, whereas AAP, since the ABO incompatibility is more common, AAP recommends only selective cord blood DAT testing involving only A positive mothers, depending upon the prevalence of ABO incompatibility and the resources available to follow up. So the aim and objective of the study were to determine the prevalence of DAT positivity and the outcomes in babies with ABO incompatibility and the role of DAT in predicting significant hyperbilirubinemia and the need for phototherapy. This was an analytical retrospective cohort study. Cord blood DAT or DCT was performed routinely in all neonates being born to O positive mothers between January 2019 to December 2020. Neonates with ABO incompatibility with gestational age of more than 35 weeks and or birth weight of more than 2 kgs were included in the study. The neonates included in the study were divided into cases and control groups based on DAT positivity status. DAT positive neonates with ABO incompatibility were included as cases, and DAT negative neonates with ABO incompatibility were included in the control group. All the neonates included in the study were evaluated for the development of jaundice, which was assessed by serum bilirubin levels. They were also assessed for the need for phototherapy, duration of phototherapy, and need for other interventions like exchange transfusion or immunoglobulin administration. It was seen that during the study period, that is January 2019 to December 2020, there were 426 ABO incompatible births with DAT positivity of 15.9% among them. It was seen that DAT positive neonates had higher peak bilirubin levels, that is 16.2, versus DAT negative newborns, which was 13.6 milligram per deciliter. The need for phototherapy within the first 24 hours was 33.8% in DAT positive neonates, whereas it was only 8.9% in DAT negative neonates. It was also seen that there was no requirement of exchange transfusion or immunoglobulin administration in DAT negative babies, whereas 2.5% of the babies in DAT positive group required exchange transfusion and 8.8% required immunoglobulin administration. It was also seen that though the sensitivity of cord blood DAT is only 29.9%, it is 96.9% specific. The conclusion was derived that DAT positivity occurs in a significant proportion of ABO incompatible births, and routine cord blood DAT testing in high-risk newborns like babies born to O-positive mothers can identify these high-risk neonates early with high diagnostic accuracy, and hence early intervention can be initiated. Thank you. Hello? Hello, am I audible?
Yes, audible. Sir is waiting.
Okay, Bhaskruti. Okay. Did you compare this DAT positive with any antibody titers?
Sir, it's not clear, sir.
Did you check this DAT positivity, DAT positivity with any antibody titers?
No, sir, antibody titers were not done.
Okay.
This
So
was
you
a qualitative assessment, sir, not quantitative assessment. Only level of positivity of DCT was seen, sir, if it was 1+ or 2+, but that was not included in the study. It was just positive babies versus negative babies.
Okay, fine. Nice. Thank you.
Thank you, sir.
Next, Preeti GD.
Yes, sir. Yes, sir.
Sir, am I clear, sir? Yes, sir. So good morning, sir. I'm Dr. Preeti JD. I'm presenting a poster on a syndromic neonate with cryptophthalmos and cardiac anomaly. My guide was Dr. Rajparat sir, Ashok sir, and Usha Nandini ma'am from Department of Pediatrics and Neonatology in SRM Medical College and Hospital. So facial dysmorphism, eye anomalies, and cardiac anomalies in combination are seen in many number of genetic disorders. Here I'm presenting a neonate with such syndromic features. We had a baby of X, born to a non-consanguineous parents, maternal age being 35 years, P2L2 mother, born by normal vaginal delivery. The first trimester scans and anomaly scans were not done. The scan at 32 weeks growth scan showed a ventricular septal defect with right eye microphthalmia. IgM torch panel was done and that was also found to be negative. So baby was an early term, 38 weeks, 3 days, with birth weight of 2.115 kg, small for gestational age, less than 3rd centile, with length measuring 47 centimeter between 10th and 50th centile, and head circumference of 32.5 centimeter, again between 10th and 50th centile. On examination, baby had a prominent forehead as seen in this picture, with a bulbous nose and a long philtrum, with right eye showing fused eyelids and cryptophthalmos. Left eye had hazy cornea and microphthalmia, with post-axial polydactyly in right upper limb and left upper limb and right lower limb as well, with flat foot and DSD with small phallus and bilateral cryptoptics. Baby was noticed to have respiratory distress at birth with the Downey score of 4 to 5 with a grade 3 systolic murmur. On examination, baby's tone was found to be normal. So we performed a 2D echo on day 1 of life, which showed a complex congenital heart disease with double outed right ventricle spectrum with ventricular septal defect with a pulmonary artery hypertension. So USG abdomen and cranium was also performed on the same day, which showed bilateral renal pelvic cases as shown in the figure with mild gallbladder sludge. USG cranium, both the sagittal and the coronal view was performed, and that was found to have normal cerebellum and normal cerebrum as well. So this course in the hospital of the baby. Baby was noticed to have respiratory distress since birth and was on the nasal CPAP support with minimal FiO2 requirement of 25 to 35%. Tube feeds was tolerated well, and baby had multiple episodes of apnea during the hospital stay. Baby eventually developed features of congestive cardiac failure by day 15 of life and was started on anti-failure measures with diuretics. Baby eventually succumbed to death on day 22 of life. So the genetic workup, what we did for this baby is considering the complex anomalous presentation of the baby, we did a karyotyping, which was done with 20 metaphyses, which was found to be normal with 46XY. And with the complex anomalous presentation, we had single genomic disorders as well in mind, like Fraser syndrome. And hence, we did a clinical exome sequencing, which showed microduplication in chromosome 13. Then, to confirm the diagnosis, we did a chromosomes and microarray, which confirmed Patau syndrome trisomy 13. Karyotyping for both the parents has also been sent, and the results are awaited. Now, Patau syndrome incidence of Patau syndrome is 1 in 10,000 births, and it has a wide phenomic presentation, as we already know, is characterized by abnormal prenatal development with maxillary cleft lip, cleft palate, ocular abnormality, post-axial polydactyly, scalp defects, and many congenital heart defects. Now, I'm presenting this case because previous studies have shown that chromosomal microarray picks up the chromosomal losses and gains throughout the genome, and it is better in diagnosing the microduplication and mosaicism in comparison with the conventional karyotyping, which we usually make the first line. Making the chromosomal microarray the first line in clinical diagnostic testing for congenital developmental disorders. I'm concluding by saying that we diagnosed this baby as a case of mosaic trisomy 13, and the chromosomal microarray should have been opted for second line investigation in such similar syndromic approach. Hello, sir. Hello, sir. Hello, sir. Am I audible, sir? Hello, sir. Hello, sir.
Wait 1 second. Sir. Sir, can I audible? Sir, your voice is not clear, sir.
Hello?
Hello, sir, your voice is not clear, sir.
No questions in that. You can close.
Oh, thank you, sir. Thank you so much.
Next, Sandeep Tilwani.
Hello, sir, am I audible?
Yes, yes.
Is my poster visible, sir?
Yes.
Yeah. Good morning, sir. I'm Sandeep from Chengalpattu Medical College. I'm presenting a case of a rare case of neonatal leukemia. So, starting initially with the case details, term 39+1 AGA baby delivered by spontaneous vaginal delivery in our hospital was discharged on day 3 of life from the postnatal ward. The baby was again readmitted on day 18 of life with complaints of lethargy, poor feeding, and fever since 1 day. And on admission, the baby had around 18% weight loss. So initially, we thought in terms of hypernatremic dehydration presenting with 18% excessive weight loss and maybe due to poor feeding. And after the initial investigations, also urea creatinine, as I have shown here, were deranged. Urea was 71 with creatinine 1.3 and sodium of 154. But strikingly, along with this, on clinical examination, the baby also had hepatosplenomegaly with delayed separation of umbilical cord. Even on day 18th of life, the umbilical cord had not separated. What was more striking is that in the CBC, HP was 14.4 with a total count of 79,000 and thrombocytopenia with a platelet count of 22,000. So we started the child initially on fluid correction for hypernatremic dehydration, and then subsequently we decided to rule out the causes for this high total count and low platelet count. So we went for a peripheral smear. I have shown the picture of the peripheral smear, and as I have pointed out with the arrow, there was the presence of blast cells in the peripheral smear. So this led to a suspicion of presence of leukemia in the child, and actually the baby at the time of admission it had typical papular blue spots on both the lower limbs. I think the picture here is not very clear, but there was the presence of this blueberry muffin spots on both the lower limbs. So we made this provisional diagnosis of leukemia cutis, and we went for an FNAC from the papular lesion. And in that FNAC also, there were the presence of blast cells, which confirmed the diagnosis of leukemia cutis. A close differential diagnosis, however, could be transient abnormal myelopoiesis, which is associated usually in babies with Down syndrome. Though phenotypically, it doesn't seem to correlate with Down syndrome. Baby had no phenotypic features of Down syndrome, but sometimes even a child who is having mosaicism at the genetic level, if he is having a mosaic pattern for Downs, sometimes they may present with this type of transient abnormal myelopoiesis with no phenotypic features of Down syndrome. So we went for a karyotype. However, the karyotype report was normal, and we then went for a flow cytometry, which confirmed the diagnosis of AML M5 variety. The child subsequently was actually shifted to a cancer super specialty hospital, but we were not successful to save the child, and child ultimately expired there on 4th day of admission. Coming to the discussion part, the neonatal leukemia is something which has an onset in the first 28 days of life, and almost all of them are congenital in origin. Neonatal leukemia accounts for less than 1% of the childhood leukemias. 2/3 of the neonatal leukemias are of the AML variety. Leukemia cutis, it is a very peculiar feature of neonatal leukemia, which is seen in around 2/3 of the babies with neonatal leukemia. It typically is described as a blueberry muffin rash. This neonatal leukemia is more commonly associated with the genetic rearrangement of the long arm of chromosome number 11, which involves the KMT2A gene. Coming to the management part, the initial part includes the supportive management, which includes mainly fluid therapy for correction of fluid therapy and correction of hyperuricemia, and use of drugs such as allopurinol or rasburicase to decrease the uric acid levels, which will be high because of the high cell breakdown. And sometimes even in cases which have very high hyperviscosity, we may even need exchange transfusion to give symptomatic relief to the baby. And next comes is the definitive therapy, which includes chemotherapy. For chemotherapy, there are different protocols for ALL and AML in newborns. So there have been worldwide collaborative studies to devise a protocol for this, which includes Interfund 99 and Interfund 2006, which are mainly related to the treatment of ALL, and AML BFM 98 2004 and 2012 for the management of AML. Thank you.
Thank you. Do you have any data of how many neonate leukemias you've seen in any units over the years?
Sir, actually, this was the first we have seen in our.
Because I think Chengalpet did report 3 years back a case of Down syndrome with leukemia. I think this the other one now, a neonate with leukemia from same institute.
Yes.
Just want to know whether leukemia in neonates very common in Chengalpet.
Yes, sir. Actually, not even leukemia. Actually, we see a high incidence of other congenital anomalies also as compared to the other centers. One of the reasons we feel could be because of we very near to a nuclear power plant, Kalpakam. So many of the patients coming from that locality, we do feel. However, I mean, we don't have any objective data. It is just something which is more of a gut feeling. We have to get some objective data to confirm it.
Yeah.
And actually, this baby's father also was working in the nuclear power plant in Kalpakam. So they took discharge at request and they went to some other hospital, cancer hospital, which was covered under the central government panel since this father was working there.
Thank you for that information.
Thank you.
Next, Harsh Jain.
Hello. Hello. Hello.
Yes, Pa, you can present.
Yes, sir.
Introduce yourself. Your screen is still not visible. Okay.
Is it visible, sir?
Yes.
I'm Harsh Jain. I'm a final year MBBS student from Sri Ramachandra Medical College. I'll be presenting about a quality improvement study we did regarding the hours of practice of kangaroo mother care. So it is a well-known fact that kangaroo mother care is beneficial for both the mother and the child. But it has been seen in several studies that its implementation is pretty limited, and the number of hours of practice remains pretty low throughout the country. So we started the study with the aim of finding the baseline hours of practice and then improving it by at least 50%. We started the study in January of 2021, and the baseline data was collected over a period of 3 weeks. We interviewed mothers and nurses to find out what the limiting factors for the practice of KMC were. The primary factors we found out were the maternal discomfort and pain post LSCS or even vaginal deliveries. Also, it was found that the nurses lack complete knowledge about the practice and advantages of KMC. And also, while practicing KMC, it was noted that because the movement of mothers was limited, the hours of practice reduced significantly because the mother had to spend time feeding or eating food herself or doing other activities. So we conducted 2 PDSA cycles to improve the hours of KMC. In the first cycle, we educated all the nurses in the KMC ward with the help of a PowerPoint presentation and detailed them about how they could help bridge the communication gap between the healthcare workers and the patient, and the importance of their role in this. So it was found that after the first PDSA cycle, the average hours of KMC practice increased from 2.9 hours at the baseline to 4.1 after the first cycle. But as you can see in the graph, during the months of April, May, June, the hours kind of fell again. Our conclusion was it was because of the second wave of COVID, the focus shifted and the practice wasn't good. So we conducted another PDSA cycle in July 2021. And we taught mothers and nurses about the KMC clot tying technique around the trunk, which basically allowed the mothers to continue some activities like feeding themselves or breastfeeding the child while practicing KMC. And also the resident doctors in the neonatology department started to mention the recommended hours of KMC in the daily charts. So we saw that after the second PDSA cycle, the hours increased to 5.2 hours on the average. And in the month of September, October, it actually reached 5.7 to 5.8 hours of practice daily, which was seen in the follow-up period after the second PDSA cycle, 3 months follow-up period. So our conclusion from the study is a simple measures like practicing proper technique and bridging the communication gap between the healthcare workers and the mothers can significantly improve the practice of KMC and improve the outcome of the babies. Thank you.
Thank you, Pa.
Next, Devaram Soumya.
There anyone more left? Any more posters?
Next, Devaram Soumya, sir.
Yes, sir.
Are there any more posters?
Yeah. Dharmala Deepti.
Sir, good morning, sir. So this is Dr. Soumya, sir, pediatric final year postgraduate from Ramachandra Medical College, sir. Poster title is Risk Factors Associated with Extrauterine Growth Restriction Among Preterms Less Than 34 Weeks, a prospective cohort study. EUGR is known to be significantly associated with adverse neurodevelopmental outcome. Understanding the risk factors associated with EUGR hence would help in optimizing the management. Aim of our study is to estimate the incidence of EUGR in preterm neonates of gestational age less than 34 weeks and to identify the factors associated with extrauterine growth restriction. This is a prospective cohort study conducted at neonatal unit in a tertiary care center between December 2019 and September 2021 and included preterms of less than 34 weeks and followed up till discharge. We excluded neonates who were discharged within 3 weeks of birth or not achieved birth weight. Clinical characteristics and anthropometry, including weight, length, and head circumference at birth and at discharge were noted. EUGR was defined as discharge weight less than 10 centile on Fenton's growth chart. Out of total 220 preterms less than 34 weeks born, 152 were included in our study and 68 were excluded. The reasons for exclusion being the discharge before 34 weeks or before achieving the birth weight or transferring the newborns to other units or declaring the before 34 weeks. And out of the 142 neonates included in our study, 83, that is 54%, had extrauterine growth restriction. The significant risk factors associated with EUGR in univariate analysis included gestational age, birth weight, SGA, duration of TPN, day of reaching full feeds, duration of respiratory support, day of initiation of KMC, and day of initiation of NNS. In multivariant analysis, we have found gestational age and day of initiation of KMC with the significant risk factor. The table 1 is showing the difference in baseline data between extrauterine growth restriction group and no EUGR group. And this, we can see among the extreme preterms, 81% had extrauterine growth restriction. And in the extreme low birth weight group, 96% had extrauterine growth restriction. And among the babies born SGA, 93% remained less than 10 centile at discharge. In the univariant analysis, we have found the lower gestational age, lower birth weight, and the longer PMA at discharge, and the longer duration of TPN, later day of initiation of day of reaching full feeds, and the longer duration of respiratory support, later day of initiation of KMC and NNS. There is significant difference between these two groups with a p-value of less than 0.05. And in the multivariant logistic regression model, we can see gestational age has significantly associated with extrauterine growth restriction. That is, a 1 unit decrease in gestational age has increased the risk for extrauterine growth restriction by 14.5 times. And 1 unit later initiation of KMC has increased the risk for extrauterine growth restriction by 1.3 times, with both significant p-value less than 0.05. And this Figure 2 is the graph showing the correlation between birth weight and weight at discharge with Pearson correlation coefficient of 0.6. And the figure 3A and 3B are the graph showing the mean calorie and mean protein intake between these two groups. And we can see that in both groups, the mean calorie and protein intake is almost similar. And when we did the unpaired t-test also, there was no significant difference between the mean protein and calorie intake between two groups. Our conclusion is the incidence of EUGR is higher in extreme low birth weight babies, and modifiable risk factors for extrauterine growth restriction identified in our study was day of initiation of KMC, the duration of respiratory support, duration of TPN, later day of reaching full feeds, later day of initiation of KMC NNS, lower birth weight and gestational age has correlated positively with extrauterine growth restriction. Hence, we strongly, since the modifiable risk factor we found was day of initiation of KMC, we strongly recommend earlier initiation of KMC. Thank you, sir.
Thank you, Pa. Very good work. Thank you.
Thank you, sir.
Next, Damalra Deepthi.
Good morning, sir. Hello. Hello. Hello.
You audible, ma'am?
Am I audible, sir?
Yes, yes.
Yeah. My topic is I'm Dr. Deepthi. I'm from Tam. Hello.
We are presenting.
Hello, sir. Hello.
இல்லப்பா ஒன்னும் லாஸ்ட் பிரசன்டேஷன் அதுன்னு இல்லை. நான் அப்பதான் பார்த்துட்டு இருக்கேன். போஸ்ட் ஓகே ஓகே ஸ்டார்ட் பிரசன்டிங் பா.
Yeah. Today my topic is short-term and long-term outcomes of therapeutic hypothermia in term neonates with HIE, and this is a decade-long experience from our unit, Tertiary Care Institute. I'm Dr. Deepthi, and this is from Department of Neonatology, Sri Ramachandra Medical College. And coming to introduction, perinatal asphyxia accounts for almost 1/3 of neonatal deaths according to NNPD data. And therapeutic hypothermia has been shown to reduce the combined outcome of mortality and major neurodevelopmental disability at 18 months of age, according to Cochrane evidence. And aims and objectives of this study is to study the clinical characteristics, complications, short-term and long-term outcomes of babies who underwent therapeutic hypothermia for HIE. So this is a single-centered observational study from 2011 to 20, and the study population included neonates fulfilling NICHT criteria and who underwent therapeutic hypothermia by ice packs or phase-changing material and semi-automated mission. And the data was collected on a preset pro forma from MRD using ICD codes and pooling registry and database of child developmental unit in our hospital. The characteristics, complications, outcomes, and those who had follow-up at 1 year were assessed. And development was assessed by a therapist using DASI or by clinical psychologist using DSID-3 at 22 to 24 months. And developmental delay was defined as DQ less than 70 and composite score less than 85. Coming to results, a total of 73 babies underwent therapeutic hypothermia. 49 were inborn and 24, that is 33% were outborn. And 17 babies of 23% had severe HIE and 56 were moderate HIE. Out of 73 babies, there were 6 deaths and 2 went AMA. And pooling was stopped in 5 babies due to PPHN and 1 protocol deviation. So we have got a total of 60 babies. And coming to adverse effects, there were normal of 52% of the babies who underwent TH were normal, and thrombocytopenia was 12%, and the PPHN in 8%, and sepsis rate is around 13%, and bleeding manifestation were observed in 15% of neonates. And discharge neurological examination was done in these babies, and 47 babies who they were found normal during discharge, and 37 babies were found abnormal, had abnormal discharge neurological examination. And MRI was done, and 18 babies had normal MRI at the time of discharge. And 29 babies with cortical abnormalities and 8 babies of both BGT and cortical anomalies. Out of these 60 patients, 1/3 of patients have been followed in child developmental unit in our hospital, out of which 60% have normal development at 22 to 24 months and 40% has a developmental delay. Out of this, 7 babies have speech delay and 15 babies have ophthalmological abnormalities. So coming to conclusion, therapeutic hypothermia could be practiced safely in neonates with HIE, as the babies who underwent TH have less adverse effects and their discharge neurological examination was found to be normal, and the follow-up was also been found 60% of 1/3 babies were found developmentally normal in our study. So it can be, we concluded by saying that this therapeutic hypothermia could be practiced safely. Thank you.
Thank you, Pa. Is it over?
All are completed, sir.
Ajit?
All are completed, sir.
All completed. No, the
Yes.
results we announce now or little later in the forum?
The podium, I think, sir.
Huh?
1 second, sir. I will tell you.
Yeah, just find out.
Dr. Arasar, Dr. Lakshmi here.
Yes, madam.
Yes, sir. இப்போ debate ஒன்னு போயிட்டு இருக்கு. இதுக்கு முன்னாடி you were not ready to announce the result. அந்த இதுல join பண்ணிக்கங்க faculty linkல.
Faculty link.
Debate முடிஞ்ச உடனே you can announce the result.
Oh, faculty link you have sent separate?
Sheikh, can you share this faculty link?
Yeah, can Ajit send me the faculty link to my mail
You
ID?
just join there. The debate is now going on. End of the debate, you can announce the result.
I'll come out of this and join there.
Yeah. Yes,
Yeah.
sir.
Thank you, ma'am.
Thank you.